disorder type stuff. Sometimes, like, you'll meet someone and go, that's clearly psychological, but most of the time, if it's a really rapid shift, it won't be. These patients to be kind of have this kind of grumbling, really, that's a problem. So the normal stuff around working with that. Challenges. So one of the really tricky things about this population is that lots of the things that happen for them mirror other things. So if you think about when you've been really sick, which hopefully has not been in the last little while, don't tend to feel particularly motivated. You know, like if you think about the last time you had the very engaged in the world, not feeling very optimistic, feeling like, you know, what's the point of all of this? I feel so terrible. You know, other kind of motivational things, can't really bother. Kind of teasing out the nuance of whether that person's just sick or whether they're depressed becomes really tricky, because actually over time it's that kind of grumbling, low motivation. It's like, oh, is that actually... Early in my career, someone mentioned is discerning that sense of state dependency. So if my cat and my, you know, puzzles and my then you can kind of go things apart. And often I'll just say to people, do you feel depressed? And usually they'll say, no, I'm just sick, like I don't. But sometimes it's a bit tricky. And like I was saying before, the other thing is, you know, people present as being really anxious, and then actually they don't really fit the mould of being really anxious. You know, and it's usually that they can't articulate to you what they're anxious about. They're just kind of presenting as really anxiety sitting in front of you. They kind of can tell you all of the. These guys don't. But sometimes, you know, you'll see people for a little while and it's like, I can't really get my handle on what's kind of going on here. And invariably, it's a back and forth stuff. So treatment and management stuff. So are what you would expect. CBT, ACT stuff, bit of existential work, and then some. So I'm just going to say, please judge away, I'm not hardcore anything. So I theoretically do all of these things, but I probably do them in a mushed up, put together, kind of pulled apart, or kind of way. I apologise if anyone is really hardcore, because the next couple of slides might be a bit offensive, but please tell me that's how other people work. So there is much people who started doing the studies were doing them in CBT. So there's been kind of probably the same as in lots of other areas. Psycho-oncology's probably been around for 20-ish years in Australia, maybe slightly longer in the States. And so the first wave is people were doing lots of work around CBT, particularly breast cancer stuff, and then it's been in the last kind of 10 years that the ACT stuff has kind of come into the fray a bit. So there's much less and I'm going to say some more controversial things. My experience of this is that people generally CBT pathway, most patients won't respond to it. And there's lots of cognitive stuff, the idea of challenging and getting rid of the thoughts that people have just actually doesn't work. So in this population, it might work in others. So things like, I'm scared that I'm going to die from my cancer, you can challenge that till the cows come home, it doesn't make any difference. And in actual fact, you're just going to alienate the person and then they're coming back to see you. So this probably of the work I do with people is very much behavioural based. Get up, get dressed, get out of bed, get moving, engage in activities, you know, all of that kind of stuff. I don't tend to keep because most of the time people don't do it, and actually this is a group of patients that have a high burden of stuff that's going on anyway, so they won't do it, so there's no point. And the cognitive stuff, sometimes I'll do some work with people if they've gotten to a thought that's really tricky. So not necessarily about challenging it, but about, okay, how might we problem solve this? All right, if you're really worried about your cancer coming back, okay, well, what happens then? What happens then? And kind of going down that line of questioning. But I'll only do that when I know that they're going to get to an end point, which invariably that end point in this population is, I'm really scared that I'm going to die. And it's like, okay, well, we can do something with that. So that's usually the kind of process by which you get there. For some patients, you just jump right there, right? Like it just stuff. Convert, just for my So I guess one of the reasons why I use ACT, well, I think I'm using ACT, is that actually in this population it fits much better. Because that idea of actually, we're not going to get rid of this. This is actually just part of your landscape now. How do we sit with it? How do we make sense of it? How do we kind of work with it so it's helpful? Stuff. What it is that we're actually doing, because it actually just fits really naturally. Like, just get. And a huge piece of that is actually, I'm seeing uncertainty. These thoughts about uncertainty are going to keep coming up, and that's, I can't get rid of them. I feel like there's a bit more controversy coming. So the mindfulness we do is really short, sharp, kind of stuff like mindful walking, or actually getting them to do full mindfulness, because most of the time they're not well enough to do. Anything, and I'll name that app or something, and it's got a body scan, don't do it, because it's not going to be helpful. You know, there's some schools of thought that actually say, no, getting them to bring attention to it is really helpful. My experience is it's not. And they tend to actually just wig out and say, I'm never doing mindfulness ever again. So I tend not to do that work with them. Other thing that I do that sounds a bit quirky, but I'll often get, if they can't tolerate adult stuff, I'll get them to do kids ones, because it's much easier for young people, but for adults as well. Like there's ones about, you know, you lay down and you blow bubbles and stuff like that. Like I always frame it with them about, you're going to feel ridiculous, but actually that visualisation piece is much easier for people to tap into than just I'm just going to focus on my breathing stuff. So the other piece, or the therapeutic piece, which is a piece that I do lots of, and it's probably, I work in, if you think back to your adolescence and kind of young adulthood, is that connection with sense of purpose and identity and meaning is already really strong. And so when you kind of layer that with a group of people that are really anxious about dying and death and dying and stuff like that, you can actually do some really nice work by just naming that and sitting with it with them, and exploring kind of all of that piece around, well, if I live from this, then what do I want my world to look like? And conversely, I'm now You know, how do I make meaning out of everything when not everything can be meaningful, kind of stuff. And you can do some really, really nice work with people. The difficulty with this work is, because there's no kind of right or wrong way to do it, and if people aren't sitting in this space, I supervise a couple of people and they're always kind of saying, I'm just not doing it, like I don't think I'm doing it right. It's like you don't get anywhere with it. Like it's not about we're actually just going to sit in this space and explore stuff. And I have the luxury of being able to do that, right? Like it's a nice, but my sense is this is actually where you get all the good work from. Shut them down. So it's like actually having that space. If any of you guys work with young people, so it'll go and whatever, then I'll be like, you know, I have a, you know, and so that piece of, so you'll be talking about that, and then that will kind of land into this, and then they'll kind of start talking about some girl that they met that they might be slightly interested in, and then we'll kind of go back to, so it's this kind of like fun meandering. So if someone was watching, just like, what the hell is she doing? But actually that stuff is, because like I said, in the population I work with, so this kind of investigation and conversation and stuff happens at the end of their lives. All of this work's already been done. And so then it's really easy to tap. How do we connect with that? What is it? You know, you always said you wanted to write letters to people. You don't want to do that anymore. What's that going to look like? You know, how do you want your time on earth to look? And I said before, get lots of other stuff that kind of, a few people on my team are doing a bit of schema work, I think, because even though I've read several books and still don't really, there's lots some really interesting articles by Michael White about grief and the idea of saying hello rather than saying goodbye, and you know, naming make sense of it, and so you can do some nice work with them around some of that stuff. So the carer piece, and I'll in a second. So piece is carers are one step removed. So even people who are there in the building all the time at all of the appointments and everything, they're not the person in the bed. And so that, and for any of you guys being carers, the challenge in that role is really hard. And so what tends, because people are one step removed, their anxiety tends to be higher. That kind of sense around loss of control feels much less controlled. And decide whether I'm going to have this treatment. I know what it feels like in my body, all of that stuff. The most effective stuff, because what happens is, you know, and we can see this coming a mile away, right? Like people just kind of carers, and in my case it's usually parents. We make this sustainable because this is going to be 6 months, a year, 2 years, 5 years, who knows. So you running around like a crazy person is not going to be sustainable for a long time. The tricky piece is that almost everyone in their world will say, oh, you need to take care of yourself. And that invariably makes carers want to punch people in the face. So I make sure that I don't say that, or at least I'm far enough away that they can't hit me. But that piece around, okay, well, what's going to kind of help get you through this? What's going to kind of float you for a bit? Parents will turn up to say, I'm just checking in, I'm struggling a bit. Underneath that is they're as terrified. Lots of the work I do with people in the room. So I would see know that I'm part of the team, and so they trust me with the information. They don't have to tell me the story, and they know that if I'm looking after them, I'm probably looking after their kids. So it works quite nicely. And so one of the things we often bought an elephant and put it in their lounge room. So like, we need to talk about the elephant. And that stuff can be really powerful, right? Because I think, you know, everyone in that space is anxious about the same thing. People exclusively. Like, nearly as big as me, actually, to be honest, but for years, right? So I had a 7-year-old in my office last week, and I was like, holy shit, what do I do with a 7-year-old? Once they're like 12 and up, I'm good. But yeah, that piece around who do they go to, because often people don't know what to do with cancer, don't know what to do with kids about cancer, and so often end up in really funny, so it wouldn't be out of the realm of possibility that they end up in your private practice, right? There is an awesome book called, I think, and I could be wrong, but I think it's called Talking to Your Kids About Cancer, and that's really helpful because it goes through like what we would expect them to know at their age, like their age stuff, and I feel like that's a really helpful thing to go through with parents, because you can actually sit down with them and go, okay, well, they with what we'd expect, and they find it really real. When I do have a little person in front of me, invariably anxious that they're going to die. The kids are very rarely anxious about that. The kids are usually worried about something completely unrelated to that. Normally try and get out what they're worried about. What do they know about cancer? Cancer, and he died. So if their whole realm is about that, then that will be their expectation. And so things around, okay, well, what do you know? What do you want them to know? Like, what have you told them? So sometimes the problem is that the parents have given them a really fluffy explanation, and the kids are like, what are you actually talking about? Because as we know, kids are concrete. So kind of odd questions that take people off guard, and it's like, oh, but why are they asking these things? I think we're missing something about it. It will probably make more sense. And I guess that piece around, do lots of work with parents around when to share stuff and when not to. Year-olds know when something's going on, right? Because they telling your adolescent kid what's going on is a horrible, horrible plan, and it will always backfire reliably. It doesn't matter whether it's their cancer or their parents' cancer, it will always go badly. So I will always talk to parents about you. Because actually once the kids have got information, then they can do something about it. All right. Too much. So, what a surprise. So I am happy to be guided by you guys around questions, thoughts, feelings, anything that might have come up in the room, you know.
Why don't you just give a case study?
I can, if you want. People happy for a case study? All right. Cool. So I've got an older person, a 45-year-old, but older than my I just want you to picture. So you've had a patient walk into your consult room. You've got one of those classic referrals that says, please see blah, blah, or, support. Yeah, totally. So Marilyn walks in. She's 45, has been married to Sean, or is married to Sean, and has 2 kids, aged 7 and 9. She works as a lawyer, and she has lots of responsibility, works really long hours. Over the past month, she's noticed some changing in her bowel habits. By the way, if you're working in cancer space, you talk a lot sputum, everything. No one told me that when I started this work. And she's been more bloated than normal. She had seen a GP who gave her a referral for a scan, however she didn't have a chance to follow up because she was busy at work. Presented to ED with significant pain in her abdomen, and a scan showed a large mass as well as disease in her liver, spleen and lungs. Primary. She have chemotherapy for several months with the potential for surgery. However, she's told that her cancer will be incurable. She identifies that she's finding it hard to manage, and her GP asked her for a practice in the community. So, she's walked in with the referral, you're looking at it. What's your first kind of... Someone's got a thought?
Have a good chat to her about how she's feeling and what the things that offer her very much from her perspective.
Yep. First question, like, why you the time for Mr. Smith is very anxious, and Mr. Smith comes in and he's not anxious at all. And it's like, oh, I just came because the doctor seemed worried when I told them that I was thinking about not doing blah. So, okay, so you're not anxious, the doctor's anxious. Different problem. Like, what would be flags? Oh, come on, help me out. I'm not going to give you all the answers. That would be too easy. Yeah, you can. Sorry?
Lifestyle changes. She's working all the time, so how is she going to manage now that she has to do the kids?
Yep. Yeah, what does it look like if she stops work or conversely tries to keep working? Say before they've started treatment normally, I'm going to keep working. So, okay, let's see how that goes. They invariably don't. There's something about that kind of, I need to hold on to this piece, which makes sense. All of us would do the same. Yep. Still in that first kind of week. About this idea of them, but it's kind of above themselves, and it's people can be really sick and have no idea, right? Not to fill you all with horror, but often people will come and say, but I wasn't sick until I had treatment, and so that kind of abstract kind of piece around, well, how do I make sense of, you're telling me, and so someone like this, she's had a kind of few symptoms, but now she's being told she's got terminal cancer. Like, those two things don't actually make any sense.
What supports?
Yep.
For her. I mean, this is shocking. He's at this age.
Yep. Yep.
How will they respond?
Yeah, totally. Her and her husband had really helpful, productive conversations about this, or have they both looked at each other and not mentioning it? And, do the kids know what's going on? Financial piece is interesting, right? Because I know it kind of falls outside of our remit, but often falls in our remit as well. Yeah, so it always comes out, right? We often assume, and we've got a hospital in a very nice part of town with a very nice shiny building. number of people that assume that because people have jobs that pay really well, is that financially they're okay, is ridiculous. So that piece, and that's, there's lots of studies coming out about financial toxicity around cancer stuff, and people really, the financial piece is such a huge, and all of that Maslow stuff, right? Like, if you can't, if you're not feeling like your housing and your food and all of that stuff is secure, then how can you even start to process what this means? Yep, totally. What's going on for her? How does she normally cope? Don't want to cast aspersions at all. But lawyers who work really hard in big city firms tend to be a little bit anxious by nature, has been my experience. Could be wrong about it, a bit perfectionistic, all of those traits that actually in cancer land are really unhelpful, because the people that everything in their stride, the people who are really anxious, all of the things we do in cancer land make people anxious. So if your level of anxiety is already quite high and you like things to be exactly the way that you like them to be, cancer land is not a place for you. It's really, really tricky for people. All right. So I'm just thinking. Fast forward, in the interest of keeping everyone awake. Good response that she doesn't need to have further surgery or chemo at this point. She appears euphoric and excited, leaving her job and going to do aid work. Check, and she denies no history of manic episodes. So what would be right? When they finish treatment, they're kind of coming in the door, it's time for me to get my life back on track. Yep, totally. And sometimes what will happen with things like ovarian cancers is that people will often be put on hormone, still kind of technically on treatment. And it depends a bit, I don't really understand. Depending on what hormones the tumour's receptors are positive or negative to, depends. Or various other things kind of just amped up quite significantly.
70, 80. So their life's going to end.
And what a juxtaposition. Terminal cancer, oh no, you're in remission now and everything's fine. Like, that's a weird space to be in. That's when my patients completely wig out. Like, so I've had patients who've been diagnosed with like terminal metastatic melanoma, and so prior to the wave of drugs that came out probably 5 years ago, if you had advanced metastatic melanoma, you were going to be dead in 5 minutes kind of thing. So these he was quite like, I should buy a pair of docs, but I don't know whether I can justify it, because what if I'm not going to be alive? Then gets this miracle drug, and then he's alive. Right? So it's like, okay, now I might live forever. What do I do with that exactly? Like, how do I make sense of that? Because it just, reasonably, right, messes with people. So one of the reasons why doctors don't give people prognosis is because like, how can you even start to make sense of that? So yeah, and we always, epiphanies and things like that. people don't generally have these big wake up. Massive evaluation about what's important or not. And so, well, I've spent all of my time working, actually is working the most important thing for me to do. Who at the end of their life says to me, or, oh, I wish I had more money. Never. People always talk about, I regret not spending time with people, my relationships are the most important things. You know, it would have been nice to travel, but even towards the end of people's, it's about relationships and connection. Which, you know, is an interesting kind of study really, and what we should probably prioritise, because I'm not sure how many of you guys work, you know, 50 hours a week, but, you know, could argue that maybe that's not the stuff we should be spending time on. It's a nice space to work in, because young patients will often remind me very subtly about what's the stuff that's important in life. What's that about? Like what's... And also, you know, as you alluded to before, what's keeping her connected? You know, like how many people do we meet that have families that they have actually no connection to at all? You know, and these are risky patients, right? You know, if you've got people that aren't connected to things, or people or stuff or ideas, then that becomes a bit worrying. Not that I think the Marilyn's going to do anything, but... so, you're feeling a bit anxious. All right, how about you come and see me sooner rather than later? She describes that she's feeling lost since her treatment finished. She's unsure of what to do next with her life. She feels that people are to her old life at all. She wants to hold on to the changes that she has experienced as a result of feeling close to death, including not sweating the small stuff. About her worries and her future, she mentions in a small from her cancer. She reports having... So what do you think then? Version of oh shit. The first one was like, oh my god, is she going to go and jump off something? Or going to do something kind of out of character? What would be going through your head now? Go on holidays. I was like, oh, you probably want to sort this out first. Yeah, totally. Because what would you expect someone to be feeling? Preventative work that you can do to help stop people do that. And often, probably about halfway through treatment, people start getting really anxious about treatment finishing, and everyone around them typically is like, oh, chemo's finishing, how awesome is this, are you going to have a party? And they're like, and have like calm, right? It's like the thing that's been keeping you alive is about to stop. What's going to happen now? And probably for someone like Marilyn, someone would have said to her, probably quite flippantly, oh, but your cancer will come back. So, and people say that stuff with good intentions, right? But it often, you know, the way people hear it isn't often kind of well received. So what else would you do with her?
Well, you try and make some positive plans about what she can do.
Mm-hmm.
Like, is she going to leave her job, or maybe work part-time, or go on a family holiday? Within her capacity.
Yeah, would you, I guess that space around going, okay, well, what is it that what feels important? How do we connect you with that stuff? The capacity for behavioural activation stuff is even less than someone who's really depressed, because they're often physically quite deconditioned as well. So if you've just come out of kind of 6 rounds of chemo, most people are pretty smashed. So that kind of idea around, well, what's going to give you purpose? And I feel like my patients are always joking with me, because they're like, do you know any other words than plan and meaning and purpose? Because that's usually to people that's, okay, what's our plan? Like, what's going to give you meaning? with her, finding out what's going to keep her connected and grounded. And probably, you know, going to be the stuff that you actually feel good about doing.
I think we also be talking about adjustments and actually taking your time. You know, you'll get somewhere that's not going to happen.
Yep.
So people changing expectations in your life over.
Yeah, totally. Yeah. And that stuff around, actually it's okay to sit in this space. You know, and for someone like Marilyn, who's probably always ran 1,000,000 miles a minute and actually probably done pretty well at life, this isn't going to feel very comfortable. And so kind of actually naming that and going, it's okay to be struggling with this because you're meant to be struggling with it. And I often talk with people about there's not many times in life you can sit in your world without any expectations, and you can do that at the end of treatment. So it's actually a nice time to actually just allow that stuff to be present and to kind of make sense of it in whatever way you need to make sense of it. And for some people that's just they go for a walk every day and that's what they do to make sense of it. But it's about that there's no kind of role for CBT stuff. One of the things that someone in this space and actually trying to keep things contained. I'll often talk with people about, okay, well let's do 20 minutes of catastrophizing about what if the cancer comes back, I'm going to manage it, yep, I'm going to die, okay, that's horrible, but then let's keep it contained to that because they're going to worry about it anyway, right? So how do we keep it contained? Yep. Yep, totally. Around planning, right? So one of that is actually once you've verbalised it, people then go, okay, well I can make sense of this. I was talking with someone the other day and they were talking about that idea that once they actually worked out that the thing they were really fearful of was dying, then that's fine. Because actually the anxiety set. So it's like, okay, well I'm not really worried about dying, I'm worried about my kids though. Okay, well what can I do about that? But for some people just the idea of even like broaching that is so anxiety filled. And for most of my patients, that worry about their cancer coming back is worse than the cancer coming back. Because once the cancer comes back, you can do about it. It's like, I'll do treatment or I'll do whatever. But that kind of piece of terrible is really, really hard to make sense of. Yeah, totally. And, you know, that piece around, you know, there's a huge piece of practicality around this, right? Like you're worried about dying. Well, what is going to happen to your kids? What's the, you know, and people often feel really relieved for doing that work because it's, and I often frame it to people around, well, let's do this as an insurance policy. It's good for a will anyway, you know. I've worked in cancer for a long time, don't have a will. So please don't hit me or kill me or something on the way home because my family would be in a state. But you know, and I talk to my colleagues, we do this stuff all day, every day. None of us have wills. But because, you know, we're perpetually avoidant as humans.